Welcome to ClinicalMedEd. This is the first episode of Sepsis 2026 guidelines. I already covered the summary guideline video, which has all the 5 changes summarized in one video. So now we are going to discuss each and every change in more detail in each episode. So the first episode is regarding the qSOFA versus NEWS2 as a screening tool for sepsis in Sepsis 2026 guidelines. Basically, the question is qSOFA dead? And if so, what is the alternative screening tool? In this particular video, we will go through all the details with clinical evidence. So please stay tuned. This is the whole journey of the Sepsis 2026 guidelines. The first summary video I've already published a week or so ago. Now you have the 5-part series coming up, episodes 1 to 5. The first episode, which is the current one, is regarding the screening tools, qSOFA versus NEWS2. We will come to that. Episode 2, which will be the next one, will be regarding fluid resuscitation and fluid removal as well. Episode 3 regarding antimicrobial antibiotic use, especially the use of beta-lactam antibiotics for prolonged infusion. Episode 4 will cover the vasopressors, the evidence, the hierarchy, and also which map targets according to age population. And the final, or the episode 5, will be regarding de-escalation of antimicrobials based on the availability of cultures as soon as possible now, which is a strong evidence. This video will be split into two. Part 1, which is the changes related to the screening tools, and part 2 of this video will cover the clinical application and examples regarding mrcp and USMLE exams. In part 1, we will cover about the qSOFA, why was it introduced in Sepsis 3 2016 guidelines, and what exactly was it intended to do at the time, and how it got sort of inappropriately used downstream. The other thing is why qSOFA fails as a standalone tool from ward's screening point of view. We will come to that. Number 3, what the NEWS and NEWS2 are. What do they mean? What are the parameters, scoring threshold, and the clinical triggers, and what actions need to be taken based on those set of variables? And finally, what is the clinical evidence base for all of these changes as per Sepsis 2026 guidelines? In part 2 of this video, we will cover the other parameters, including clinical application of all these tools, exact wording, the distinction between a screening tool and a diagnostic tool. So that's the key thing, because screening and diagnosis will be two different things. And practical implication, if your hospital uses qSOFA or doesn't use NEWS2, what should be done, and some of the exam traps for the candidates. Let's recap the definition of sepsis. I've already covered it in detail in our summary video, Sepsis 2026. Basically, the Sepsis 3 definition has remained unchanged in the 2016 guidelines and the 2026 guidelines. In essence, sepsis means life-threatening organ dysfunction caused by a dysregulated host response to infection. And when we say organ dysfunction, we are talking about the acute increase in the SOFA score. Remember, SOFA, not qSOFA. SOFA score of 2 or more points from the baseline. Now, this definition I've covered as I said in the video, in the earlier video. I would like to read it in reverse, and I'm sure you would appreciate why do I say that. So if you read the same sentence backwards: infection, host response, dysregulation, then organ dysfunction, and then life-threatening. Now, let us put it in a proper sentence. So it's basically an infection leading to the host response in the body, human body in this case, infection leading to host response, which becomes dysregulated, and that leads to vital organ dysfunction, which can become life-threatening. All this equals sepsis. I think now it makes sense. If you read forward, life-threatening organ dysfunction caused by a dysregulated host response to infection, or infection leading to a dysregulated host response, which eventually leads to organ dysfunction, which can be potentially life-threatening. This is sepsis. I think this AU, MedEd Quartet, is the gold standard definition of sepsis and remains unchanged. So let's look at 3 aspects: infection, organ dysfunction, dysregulated host response. Infection can be either a suspected or confirmed infection, and it could be any organism, any pathogen, bacterial, viral, fungal, or other infectious etiology. The key concept is that the harm doesn't occur because of the infection itself. It's an infection plus a dysregulated host response. Now, if it's a regulated, controlled host response, that will eventually control and treat and help in the infection resolution. However, if the dysregulated host response occurs, that will lead to a problem and sepsis. And it's not just a pathogen burden alone. So this is the key thing. Again, our AG, homeostatic dove, gives us the concept of imbalance between the host response to infection and the infection itself. In terms of organ dysfunction, the SOFA score means 2 or more points rise from the baseline. And all the vital organs include the heart, lungs, liver, kidneys, brain, and then I say the coagulation, which means the blood's connecting all these vital organs. I've covered the mnemonic in my initial video, but basically you have different parameters. I can't go into more details, but there are 6 vital organs with each one has up to 4 points. So it can range from 0 to 24. And based on that, the organ dysfunction can be characterized in the scoring done. Finally, coming to the dysregulated host response, we've already covered basically the immune response. If it's checked within confines, within limits, it's regulated. It means it's going to do the intended job which it should be doing. However, when it becomes dysregulated, maladaptive, and either it's insufficient or it's excessive, that can lead to harm and that can lead to damage. And what does it mean? It means it could be pro-inflammatory condition, it can be endothelial dysfunction, endothelial damage, coagulopathy leading to disseminated intravascular coagulation, which eventually leads to, at the microcirculation level, macro and microcirculation level, it can lead to organ dysfunction in all the respective organs. And eventually, this all becomes a harbinger for the microcirculatory and metabolic dysfunction, which ultimately leads to organ dysfunction. And if it remains unchecked or unsupported or uncorrected, that can lead to organ failure. And sequential multi-organ failure becomes critical to eventually, leading to the higher mortality. So hence, the more the number of vital organs are affected, dysfunction, and going to the organ failures, that can lead to higher risk of mortality for such patients. So basically, in Sepsis 3, the qSOFA was designed, and even before that, it was designed as a quick bedside predictor of poor outcomes in patients of suspected with infection outside of the ICU setting. It was never designed to be a screening tool for sepsis on the ward. So this is important. It's like a mortality predictor, but not a screening tool for diagnosis. So this is the key problem, and I've already discussed in the first and main video as well. So what happened down the line is the intended use of qSOFA got forgotten or misapplied, and the main intention was prognostic tool in ED or out of ICU settings on medical wards, and it was a predictor of prolonged ICU stay and in-hospital mortality. And it uses 3 quick, literally 3-second bedside assessment of. And those 3 scoring tools are altered mental status, anybody with a GCS of less than 15, even if it's a 1-point drop, respiratory rate of above 22 or above, and it's a single threshold. So all the 3 variables are binary. And number 3 is systolic blood pressure of 100 or less. And again, it's an absolute value only. So any 2 of these being positive was considered to be high risk of poor outcomes. And the main purpose of qSOFA was to flag those patients for a senior clinician review rather than using them as a screening tool, which ultimately, unfortunately, happened. Instead of the intended use, people started using it as a primary sepsis screening tool, which it was not meant to do. And also, they started using it as to activate the sepsis pathway, which it was not meant to do. And it was used as a gating criteria for urgent treatment. Anybody with a qSOFA of above 2 should need immediate treatment. That was not its initial intention. And in some settings, they started using it as a replacement for EWS system, early warning score system, like a quick 3-point bedside tool. Doesn't really make any sense because EWS has more variables rather than just binary or binary, two variable, two criteria, either this or that. No, it's more variables, more diversified, and better equipped for higher sensitivity and specificity. A one-liner summary of this slide is, and the problem with qSOFA versus EWS is that qSOFA was a prognostic tool misapplied as a screening tool over the years. And this mismatch eventually led to the Surviving Sepsis Campaign 2026 guidelines to correct and rectify this particular error. So what basically is a problem with qSOFA as a screening tool for sepsis? First of all, this is a bit confusing. So just pay attention in this slide and the subsequent two slides. And the 73% figure makes it a little bit more confusing, should I say, because it's similar in two separate studies. First of all, Wang et al. In 2022, there is a meta-analysis of 26 studies pooled involving nearly 62,000 patients with suspected sepsis outside ICU. So remember, as we discussed before, qSOFA is a tool to predict mortality in patients with sepsis outside of ICU. It's not a screening tool at all. So that meta-analysis itself, actually, it involved, as I said, more than 62,000 patients with suspected sepsis. And qSOFA had a pooled sensitivity of approximately 46%. Some other studies quoted between 46 to 51. So roughly around 50, you might, just for the ease of remembering, just under half. In terms of NEWS, remember we're not talking about NEWS2, we're talking about the NEWS, National Early Warning Score. The same prediction for mortality sensitivity was 73%. Okay, so this means qSOFA head-to-head versus NEWS in even predicting mortality in septic patients outside ICU setting, it was missing almost half of the patients. Now, another twist to this story is that qSOFA is more specific, around 82% as compared to 52% for the NEWS. Therefore, a positive qSOFA still remains a clinically meaningful and identifies high-risk patients, but a negative cannot exclude sepsis. So this is the limitation. And also the difference could also be because qSOFA is a binary or binary, or whichever way you pronounce in the US and continental Europe or England. So if you look at the binary variables, it's dichotomous. It's two, either this or this. So there is no continuous variable like NEWS. In NEWS, you have different variables and many scoring grids, and that makes it more physiologically appropriate to use. And even for oxygen, it has a separate score for all supplemental oxygen. In the next slide, I will discuss about the key evidence for the meta-analysis which the Surviving Sepsis Campaign 2026 used for screening tool point of view. So, but for this slide, please remember 46 versus 73, same meta-analysis, Wang et al. 2022. The purpose was not screening, the purpose was for prediction of mortality outside ICU settings in patients with sepsis by using qSOFA versus NEWS. Okay, qSOFA NEWS, not NEWS2, 46, 73%. So sensitivity. So this is the key take-home message in this slide. So let's look at the actual evidence of the head-to-head analysis of different tools for screening purposes of sepsis. This is important. Now, the pre-hospital evidence which the Surviving Sepsis Campaign 26 leans on comes from a German cohort of more than 200,000 patients, 221,000 plus patients, and emergency medical service EMS cases from Piedmont and colleagues published in journal Infection in 2024. It was a retrospective cohort study with claims data from EMS cases, paramedics, and emergency physicians. They looked at how many people, how many of those patients eventually turned out to have sepsis as a diagnosis, etc., etc. So based on different analysis, they calculated 5 screening scores and tested how well each predicted a later inpatient diagnosis of sepsis. And not surprisingly, if you look at the graphs, the line graphs, NEWS2 came out on top with a sensitivity of 73.1%. Now, this 73.1 is the one that I was saying confusion with the previous slide. So that 73 and this 73 are two totally different, two different studies. So do not please do not confuse this number. So in NEWS2 had 73.1% sensitivity and a specificity of 81.6%. qSOFA came out at the bottom of the table with just 23.1% sensitivity. Now, this is to predict as a screening tool to predict sepsis. Now, remember the qSOFA in the previous study was 46% sensitivity. That was to predict the out of ICU mortality in patients with sepsis. So, two different studies, two different endpoints. So, here qSOFA is at the bottom of the tree. And again, the honest limitation is that the NEWS2 specificity of 81.6% still left a positive predictive value of 6.5%, which is, a lot of false alarms. It means that the reason for that is that the total cohort had hardly 1.7% patients with sepsis. So it was a very, out of a large pool, a small proportion had sepsis, and that's why the positive predictive value dropped down. Anyhow, from sensitivity point of view, it was NEWS2 had highest sensitivity, 73.1%, while qSOFA had the lowest one. So basically, that's why the Surviving Sepsis Campaign 26 recommended, the panel, expert panel recommended that NEWS2, MUSE, which is modified early warning scores, or SIRS, all of them are preferred over qSOFA. So that's why the title or the topic slide was qSOFA out, NEWS2 in. Okay, and the reason is NEWS2 amongst all of them has the highest sensitivity of all. However, please remember that the panel itself does not recommend NEWS2 as such. It just gives a generic instruction of using any of these other than qSOFA. And the take-home message, please remember that none of these scoring tools is to diagnose sepsis. So please remember, these are screening. The sepsis has to be a clinical diagnosis, not based on a screening tool. And once you screen for possible sepsis, then you need to do your clinical judgment and the next steps really. Okay, this is one of my very favorite slides. The two studies side by side. What's the clinical evidence? On the left, you have Wang 2022, a meta-analysis of 26 studies over 62,000 patients included, looking at the mortality in suspected patients across emergency department and ward settings. We've said it, out of ICU settings. qSOFA sensitivity is around 46% versus NEWS of 73%. Okay, established. On the right side, we have the Piedmont 2024 published in the year 2024. We've just discussed it previously. Retrospective single cohort of 221,000 plus patients. Pre-hospital cases, EMS related, completely different endpoint. It was to identify who turns out to have sepsis using different screening tools. And what it showed was a qSOFA had a sensitivity of 23.1% versus NEWS2 of 73.1%. Okay. Now, if you look at side by side, these two are different methods, different populations, and different endpoints, and the same signal, which means qSOFA is consistently missing far more patients. But two key points to remember, like the nuances that you should remember here, that the qSOFA's sensitivity depends upon the endpoint, and it looks worse for pre-hospital screening than for the pool mortality in hospital, and both are low, by the way. And the other thing which I have said like earlier on in a couple of slides ago is, just look at the 73% figure for NEWS and NEWS2 in both studies. This is the confusing point. A lot of people, when they compare head to head of qSOFA versus NEWS2 sensitivity, they quote as if it's the same. No, qSOFA compared the NEWS for sensitivity of mortality, while the Piedmont study only looked at the analysis of the different screening tools, and one of them was NEWS2. So this 73% versus 73.1 is very confusing in both studies. So please remember, it's not the same study and not the same endpoint. And the key message is that neither of the two scores is to diagnose sepsis, and a low score does not rule it out. So clinical judgment is the most prudent way forward. So this is the NEWS2 tool. which is used by most of the NHS hospitals in the UK, and globally or similar tools are used. So this is specific and recommended by the Royal College of Physicians in the United Kingdom. So basically you have 7 parameters but 8 cards. Why? Because oxygen saturation SpO2 has 2 scales. The key points are that there are 7 physiological parameters versus qSOFA's 3. That's why it was binary, it was dichotomous. We have discussed this previously, and hence better sensitivity for NEWS2 as compared to qSOFA. That's why in this situation you can think of AG and ORM as our gold standard. Each parameter is weighted and the score reflects the severity of each threshold. So you can see the top row is full related to respiratory and saturation. So respiratory rate, peripheral oxygen saturation, scale 1, scale 2. Scale 2 is somebody with hypercapnic respiratory failure like COPD, and then use of supplemental oxygen. So that's the oxygen grade, the top 4. The bottom 4 are the other variables, 3 vitals, so systolic blood pressure in millimeters of mercury, pulse rate per minute, temperature, and fourthly, the consciousness. It used to be FPU, alert, responding to voice, pain, and unresponsive. Now the C has been included. So it's ACVPU, which means alert, confused, which is new confusion to differentiate from chronic cognitive dysfunction, responding to voice, pain, and finally unresponsive. So these are the scores. And if you look at the basically the temperature in this scale is included. It's a key sepsis parameter that qSOFA does not capture. So again, hyperpyrexia or hypothermia are one of the key features in sepsis. The total range for all these parameters is from 0 to 20. Any NEWS2 score of 5 or above will necessitate urgent clinical review from a physician on the unit. And a NEWS score of 7 or more means emergency clinical review. It has to be stat as soon as possible. And any score of 3 on a single parameter will also need urgent clinical review. And this slide is basically just the same infographic. I've just split up all the parameters into the traffic light signal, colors, red, orange, and green. Coming to the action points, once you have the scoring grid, you have calculated the NEWS2 score. As ever, any score of less than 5, which means 0 to 4, means just routine monitoring, and the observations can be 4 to 12 hourly. Medium risk with a score of 5 to 6 or 3 in any single parameter means urgent review within 1 hour, and you can increase the frequency of observations. And high risk means a score of 7 and above means emergency assessment as soon as possible, and critical care outreach team or medical emergency teams based on the local protocol you can activate. You can get in touch with them, a rapid response team, depending upon the local facilities. And you might consider escalation to high dependency unit or critical care ICU units accordingly. And once you have a NEWS of 5 or above and the patient has a suspected infection, then you consider the sepsis pathway or the golden hour or the sepsis resuscitation bundle, depending upon your local policies and protocols. And the same concept for the NEWS2 in a graphic manner. Step 1, you calculate the NEWS2 based on the scoring grid of the physiological parameters, supplemental oxygen, etc. Score of 0 to 20. All these parameters are mentioned here. Step number 2 is the clinical escalation threshold. And the second half of this infographic is for the rest of the parameters as we have discussed before, including frequency of monitoring based on the score. Again, use your local policies and guidelines. There cannot be one size fits all. And the key principles in the middle, and when to consider sepsis pathway, as you said before, NEWS2 score of 5 or above, and clinical suspicion of infection, then you can activate the sepsis resuscitation bundle. The second part of this episode, which is the clinical pearls, mrcp exams, USMLE exams, really important for you to understand as trainee or as any healthcare physician, any doctor, of difference between the screening and the diagnostic tools. So screening is to screen sepsis, diagnosis is to diagnose sepsis. What are the screening tools? We have discussed NEWS2, NEWS, MUSE, SIRS. What are the diagnostic tools or the diagnosis? It's a sepsis 3 criteria that is totally unchanged in sepsis 2026 guidelines. That has not been touched at all. So in terms of screening, you want to assess or screen patients who may have sepsis from a broader unselected population. It's applied, as we have said, NEWS criteria of 5 or above, or institutional EWS. Please follow your local guidelines, and possibility or suspicion of infection. And what's the clinical action? Once you have that, immediately use sepsis 6 resuscitation bundle, etc. And now this is a strong recommendation in the guideline of how to screen and how to go forward. So that's the sepsis 2026 guidelines. In terms of diagnostic criteria, they have totally unchanged. It's the same sepsis 3 criteria as before. The confirmation means the patient has sepsis based on objective organ dysfunction score. Now, please remember suspected infection plus SOFA score of 2 and above, not qSOFA. This is important, and the rise should be 2 or above from the baseline. And clinical action means now you have sepsis diagnosis, you can trigger the full bundle and guideline documentation. And this has not changed in the 2026 guideline. Now, this is the single most important conceptual distinction in this particular episode. So many candidates, exam candidates, will think of conflation or conflating qSOFA with sepsis 3 diagnostic criteria. Please remember they are separate. And I'll go through in a little bit of a more sequence. For sepsis, you need to screen first, diagnose second, and prognosticate third. So in this order, for screening, you need NEWS2. For diagnosis, you need the sepsis 3, and in that you have SOFA score, and finally the prognostication is qSOFA. So NEWS2 for screening, SOFA score of 2 and above points rise for diagnosis purposes, and the qSOFA of 2 and above for prognostication of out of ICU setting. So this is the key thing. And the Surviving Sepsis Campaign 2026 only changed the screening layer. The diagnostic and prognostic has not changed. And that means the prognostic qSOFA, which used to be misused or wrongly applied higher up in the screening, has gone back to the prognostic area, not the screening area. And in mrcp PACES exam, if you're asked a question, okay, how do you diagnose sepsis? So the answer should be, in addition to other clinical information based on the scenario or station, the diagnosis, how do you diagnose sepsis? Your answer should be by using sepsis 3 criteria, which means suspected infection plus a SOFA score of 2 or above, rise of SOFA score of 2 and above from the baseline. Do not say the patient has a qSOFA of 2 and above. So this slide is just a brief snapshot of practical implementation of the early warning scores. If you're already using, or if a hospital or a department is using NEWS2, MUSE, carry on doing so, incorporate your sepsis 26 guidelines accordingly. If you're using qSOFA or department is using qSOFA, it might be the right time to think of changing to more standardized scoring systems as per sepsis 26 guidelines. And in hospitals or resource limited centers where there is nothing, none of them are used, and it's the right time to teach, educate, orientate trainees and clinicians and nursing staff, and come up with the standardization of the early warning scores and incorporate sepsis 2026 guidelines. Again, it's a recommendation. Please follow your local institutional policy. It's just an educational video. It's not mandatory, but best practice should always be adopted according to the clinical evidence. So this is the last slide, and for exam purposes and also for a summary. On the left column, what's not recommended, what is retained, and what is new in the guidelines. It's just a summary of what we have discussed so far. So both qSOFA and even SOFA as a screening tool are not recommended. We've touched upon most of them already. What's retained is the sepsis 3 definition. The diagnostic criteria has totally unchanged, and that includes SOFA score, not qSOFA. Okay, and septic shock definition is also the same. qSOFA is a prognostic tool, still there. Remember, difference between screening and prognostic tool. What's new is that the there is no single recommendation as such from the Surviving Sepsis Campaign 26 guidelines, but they have recommended using NEWS2, NEWS, MUSE, or SIRS instead of qSOFA. And the evidence strongly suggests that NEWS2 is the best in terms of the sensitivity. Although the guidelines per se have not labeled or named NEWS2 as the sole screening tool. So this is the caveat. So please remember that. And performance improvement audits by institutional departments and hospitals should be implemented for standardized screening and for high risk and acutely ill patients. With that, I leave you with this episode. And coming up next will be episode 2 on the fluids and fluid resuscitation. And that will be episode 2 of 5 of Sepsis 2026 guidelines. Thank you so much for watching.